So for our next session on health equity among diverse populations, we're excited to be able to talk about a topic where we're going to highlight some of the inequities that's been created by COVID-19 among different populations based on income, location, race, and religion. We're going to hear about how the Stanford communities and Rambam communities address these healthcare disparities. Our speakers today are the following. We have Dr. Kenji Taylor, who is a family medicine physician at Stanford, researcher, implementer, activist, and educator. Excited about the potential for innovative care models, financing, and technology to improve the health of underserved populations. Next, we have Dr. Khetam Hussein, who is the Director of Infection Control Service at Rambam Healthcare Campus. Dr. Hussein is an assistant professor of the Technion Faculty of Medicine and has published many papers in leading journals on the field of multi-drug resistant pathogens, hospital-acquired infections, and infection control. Finally, we have Dr. Katherine Staats, who's an assistant professor in Department of Emergency Medicine. She's dual boarded in emergency medicine and emergency medical services and serves as the Imperial County EMS Medical Director and Santa Clara County Fire Medical Director. So let's start with Dr. Taylor. And again, please feel free to submit your questions through the chat box. And Dr. Taylor, go ahead and share your slides. Thank you.
Great, thanks so much. Can I get a thumbs up? I'm sounding okay? All right, excellent. I do have a few slides to share here that I'll walk us through, if you'll bear with me just a minute. Well, good morning, everyone. Thank you, Dr. Shem, for the opportunity to speak with you all today. This is such an exciting venue and couldn't be more timely. I'd like to talk to you just and make a few comments about health equity for the Black community in the United States in the context of COVID-19 and how we address that through academic community partnerships. And there are really three main points here that I would like you to walk away with. One is that COVID follows a well-trodden path, actually, of widely known health disparities among Blacks in the United States. Two, in order to achieve health equity and justice, we must acknowledge and address social determinants of health. And three, community partnership is critical to reach historically underserved, marginalized, and hard to reach populations. So overall, we know that Blacks have higher rates of mortality than any other race or ethnic group in 8 of the 10 top causes of death in the US. These persistent disparities account for at least 60,000 excess deaths per year. When we look from 1985 to 2013 and at age-adjusted death rates for Blacks, you'll see that we're making progress towards health equity around cancer, for example. In other areas like stroke and diabetes, we're at least maintaining ground. And then in other areas such as homicide, these disparities are glaring and even widening. I would imagine you can't watch the news or open up an Instagram or Twitter feed or read the US newspaper these days without seeing that these numbers are actually people today. People like Ahmaud Arbery, Breonna Taylor, and George Floyd, whose murder was the spark of the Black Lives Matter re-innovation here in the United States. And these disparities in health equity issues have impacted generations of African Americans in this country and still continue to this day. So sadly, COVID does follow these cracks that we've seen here in health disparities. In this chart here, you'll see that Blacks account for 12% of the population here in this gray bar, and yet are 21% of shares of death nationally and 19% of cases. Along with the Hispanic community, COVID has shown disproportionately impact to these communities. And finally, when we zoom into Alameda County, here, Stanford's neighboring county, where I practice medicine and partner with communities on research, you can see that these disparities persist in even greater extent, where Blacks in this part of the country make up a larger proportion. We see that the death rate per 100,000 is significantly higher than any other group here in this area. So in order to really understand how to address these disparities, it's really important to define and understand the following terms: equality, equity, and justice. I like this very commonly used diagram to illustrate the difference and realize it's not perfect, but it's a simple snapshot to keep in your mind. So on the left, you have the idea of equality. You've got three people standing on an uneven playing field and an uneven fence that advantages the blue person, despite all other things being equal. So really only the blue person can see and participate in the baseball game in front of them. In the picture, the middle picture we have depicting equity, in order to address some of this uneven ground and fence, the yellow person and the red person get extra boxes so they can see over the fence. And then finally, really where we're striving towards is justice and or some people might call liberation, where all people are working to dismantle that fence and those structural barriers. They're probably leveling that grass level field so that in a just world, we have removed those structural barriers leading to inequity in the first place. So I really, carrying that analogy forward, what is the uneven ground and what does that fence look like in the context of COVID-19 and health disparities? I really like this particular diagram here, where on the left in the green, you have the social determinants of health here, and then on the right, you have the solutions to these determinants of health that impact the disparities that we see in COVID. And I'm going to focus in particular around this red circle here in partnership with community members. So when I think about addressing social determinants of health, I'm really proud to say that Stanford has partnered with a really great organization, the Roots Community Health Center, that has been doing this work since 2008. Roots is a community health center that is headquartered in Alameda County, where I had displayed some of those disparities earlier on in COVID. They're a center that serves Medi-Cal or publicly insured patient population focused on people of African descent. And really the heart of their model is the whole person care model, where they have integrated medical and behavioral health care that also integrates food, employment, benefits, and economic empowerment programs as well, really thinking holistically about those social determinants of health. And they've been a partner with us since this past September 2019. And a real key part of them delivering that whole person care model is a large cadre of community health workers that are tightly interwoven into their delivery model. So, the COVID pandemic has really accelerated this partnership and allowed Stanford to support an organization that has already been doing the challenging work of addressing social determinants of health and health disparities in the Black community. Related to COVID, we partner with Roots in three main categories: testing, information sharing, and research. Through the testing partnerships, Stanford early in the pandemic donated test kits, served as a reference lab, and offered access to drive-through testing as additional testing partners with Roots came on board. To share information, Stanford hosted weekly grand rounds open to Roots staff and clinicians, shared occupational health guides and clinical questions databases. And then Roots on the other end helped Stanford really understand on the ground level what the local community need looked like and what strategies were working to reach key populations to control the pandemic here. And finally, in the realm of research, just a couple of examples where we're partnering around wearable symptom tracking among staff and higher risk patients living in congregate living settings, and also conducting a rapid needs assessment as the pandemic has continued. And shameless self-promotion, but in case you're interested in reading a bit more about this, our group published a paper in the Journal of the American Board of Family Medicine, where we really detail this partnership. And finally, I'll just wrap up and talk about really highlighting a community level outreach, and in particular, the Cut Hypertension program, which is a program I started in 2010 that partners with Black barbershops to provide outreach and treatment for high blood pressure. When COVID shut down shops in the United States, we heard a clear message from our barbers that they wanted ongoing support related to COVID. And so that came in the form of the following: a national survey of the needs and assets of Black barbershops to respond to COVID-19, a working group that partnered with the California Barbering Board around protocol for safe reopening, contact tracing with barber partners who were actually based at Roots as well, and then a national convening that kicked off this prior month with 8 barber programs across the country and 40 participants. And finally, a planned community-based training this coming month around health coaching, vaccine education now is the next big thing, and COVID safety practices as shops continue and start to reopen again. So with that, thank you again for your time and for letting me make a few comments, and hope again that you can walk away with these 3 points.
Thank you, Dr. Taylor. Next, we have Dr. Hussein. Please feel free to share your slides.
Again, start saying good afternoon or good morning for our colleagues at the Stanford, and thank you for giving me this opportunity to be part of this important event. In the few next minutes, I will talk about the unique aspects of Arab population in facing COVID-19 outbreak. Arabs constitute about 21% of all the Israeli population, and most of Israeli Arabs live in the north of Israel in separate villages and towns. And during the first wave of COVID-19, only 6% of all confirmed cases in Israel came from the Arab community, but this has changed during the second wave, and it increased almost 22% of all the confirmed cases in Israel. And if we look at Rambam, in the first wave, we have 12% of all our hospitalized patients from the Arab community. To remind you, we are the biggest hospital at the north of Israel, where most of our population lives. But during the second wave, almost 40% of all COVID-19 hospitalized patients at Rambam were from the Arab community. So what happened? What changed and caused this rise and increase in numbers? There are multiple factors that cause this increase in the Arab population, and the first and most important is the cultural norms and traditional living arrangements among Arab citizens who typically belong to large families living in close proximity to one another, including senior citizens living with children and grandchildren in the same house. So that makes social distancing unachievable and almost impossible. And another important factor was the holidays, and there was the most important holiday for Muslims and Druze communities at the end of July, Eid al-Adha, that policymakers, MOH, marked it as the main event that will cause a rise in the new COVID-19 cases among Arab citizens. But actually, if you look at the data from MOH, you can see that almost a month and a half before this holiday, we started to see the rise in numbers in the Arab community. So what happened? What happened is the weddings. Yeah, weddings are important events in the Arab community. They are large gatherings with hundreds and thousands of guests. It's like you have to share others with their weddings. It's not acceptable that you don't go to these weddings. And according to the MOH data, for every 100 participants in these weddings, there were 7 guests that contracted the virus. So besides these cultural norms, there were the religious beliefs, the statement that we are immune because of the low numbers in the first wave, as in other communities, corona denial, COVID is a lie, the political conspiracy theories, and also the social pressure to be part of all these weddings and not to put a mask, and the shame to being a patient. but every coin has two sides, and the other side is the MOH publicity, or actually the lack of this publicity in Arabic. Actually, the first MOH serious campaign didn't come until the end of the first wave, the end of April, before the Ramadan. All the first wave, there were nothing in Arabic as from the MOH, and also there was unavailability of tests. If you look at the MOH data, you can see that a number of tests among our population was much lower than the rest of the population, and the positivity rate was much higher. Also, the unstable employment. 80% of all Arab workers are a service or manual workers that are can't work from home, and they have to work in order to survive and provide their families. Also, the low level of emergency preparedness in the Arab community. Until this outbreak, actually, all the previous emergencies in Israel were somewhat related to conflicts in the area, and the Arab community in Israel weren't part of this emergency preparedness. And also the digital gap with a poor internet and cellular infrastructure. All these factors together led to the mistrust in government, mistrust in Minister of Health, and also for the Arab population to be in compliance with the Minister of Health instructions. But in every there's a hope and there's a light in the points of light, and one of these points of light is that the public still trusts us, still trust the medical professionals, and more than politicians and more than financial experts. And actually, we used this trust, and our Rambam Arab employees, besides they're being fighters in the front lines, shoulder by shoulder with our Jews colleagues, they almost from day one of this outbreak led campaigns and publicity for Arab communities. We were almost in the media, in the social media, in the radio, in the television, and we prepared brochures in Arabic to explain about the virus, the disease, how to protect ourselves. And our main goal was to raise the knowledge of the Arabic population about the virus, and to increase the compliance with the instructions, and to raise the sense of responsibility among our people, our back at home, for the importance of keeping the instructions and in fighting this virus. So thank you again, and be safe.
Thank you, Dr. Hussein. Next up, we have Dr. Kathy Staats. Kathy, feel free to share your slides.
Excellent. Thank you so much. So my name is Dr. Kathy Staats, and I'm the Imperial County EMS Medical Director. Today, I'm going to chat with you briefly about a surge that we experienced in Imperial County from May through July of this year, and how we responded in a very resource-poor region. So where is Imperial County? Imperial County is at the southeastmost corner of California, down here at the bottom right of your screen. You can see it's bordered by 2 other California counties, as well as the state of Arizona. And most importantly, its southern border is bordered by that of Baja, Mexico. Now, within our county, we have only approximately 180,000 persons, but in the city just south to us, we have 1.2 million people, and approximately 1/5 to 1/4 of those persons can cross freely from Mexico to the US back and forth based on being legal residents or US citizens. Now, this is important because this is one of the busiest border crossings in the United States. It's the 3rd busiest. A significant percentage of our workers within Imperial County live in Mexico and every single day commute across this border. Prior to COVID beginning, there were 50,000 persons crossing per day. And during COVID, that number dropped to 25,000, which is still a very high number. Now, why is this important? Well, within Imperial County, agriculture is our main industry, and the farm workers that live in Mexico and cross daily are critical for our economic livelihood. Secondly, we are a binational community. Up to 90% of our community identifies as Latinx, and that means that family and friends live on both sides of the border, and moving freely is very important to our social livelihood. Unfortunately, we do have some of the highest rates of unemployment in the state at 23.5%. And we also have some of the highest rates of asthma, tuberculosis, and diabetes. And we share those last 2 bits of information to sort of frame the likelihood and predisposition for severe COVID disease prior to COVID beginning. For our healthcare system, we have 2 hospitals that serve the majority of our healthcare needs. Prior to COVID, and this is for 180,000 people, we had only 22 ICU beds in the county and a total of 160 beds overall. 1 intensivist worked within the county, and we had no tertiary care centers. So things like STEMI, stroke, peds, that would all typically be flown out. So our response to the pandemic, initially, Imperial County was doing very well, just like the rest of California. We had been socially distancing, doing some face coverings. But unfortunately, when just south of us in Baja, Mexico, they began to see a spike in their numbers, as we do have a very high level of movement back and forth, we began to see a spike ourselves. And beginning on May 19th and lasting through mid to late July, we had a very severe COVID surge within the county that taxed both our pre-hospital and hospital systems to the max. Unfortunately, we made all the major news outlets within the United States, and the way we chose to respond was with this 3-pronged disaster model. So first, continue to emphasize non-pharmaceutical interventions to flatten the curve as much as possible. Second, increase our local capacity for care. And then third, use our approach within the framework of the incident command structure. So with the NPIs, as much as we did encourage masking and social distancing, unfortunately, we were not a closed system, and it was limited by if Baja, Mexico, surrounding counties or surrounding states were not practicing these, our NPIs would only go so far. For the second aspect, for increasing local capacity, we did focus on increasing ICU and hospital bed at both hospitals. We had tents placed outside both EDs, specifically for lower acuity COVID patients. So if they needed a swab only, they were able to be swabbed and not take up a hospital bed. We did obtain tele-ICU for patients, and then a field medical station, later renamed an alternate care site, was created. This alternate care site was critical for the response within Imperial. It was a gymnasium that initially was able to take SNF or skilled nursing facility level patients, and eventually was bumped up to med-surg level. And so we were able to significantly offload hospital days where patients often had been in the ICU or med-surg level, were not quite ready to go home, but it was more appropriate for those hospital beds to have higher acuity patients. At the end of its time, it was one of the busiest ACSs in the state that saw the highest number of patients. When our local capacity did become outstripped, we did have to transfer out several patients, over 600, which was a very logistically challenging event that involved local, regional, and state partnerships contacting each other daily and sometimes hourly to make it work. Patients went as far north as Sacramento, which is 8 hours by car, and also typically was done by air. Overall, Imperial County had 4 times the next closest infection rate per 100,000 in the state at its worst. By increasing capacity and transferring out of county, we were able to respond. And then overall, we focused back to 2 main principles: basic disaster response framework using ICS and using adaptation and innovation for COVID-specific issues. Thank you.
Thank you to all the speakers. We have 5 minutes to answer some questions. First one I wanted to pose is, we've been hearing the press, obviously with Pfizer and the vaccine coming out, and I'd love to get your perspective in terms of the role of community-based work and how that goes about in understanding the dissemination of vaccine. Let's start with you, Dr. Taylor.
Yeah, thanks so much for that question. I think it really is timely, and I think the role of the community and education around vaccinations that really reach, I think, some of the historically underserved patient populations is so important. I think kind of thinking through the conversations that I've had with barbers and why we had initially partnered with Black barbers around hypertension education and treatment was because within the Black community, there's a long history of medical mistrust for very good reason of the system here in the United States. And so a lot of Black men in the Black community really look to their local leaders to get that information. And we know from prior vaccine dissemination programs in the country, the United States, that this community engagement has been really important in really increasing our uptake of vaccinations, in particular around measles, mumps, and rubella. There's a lot of good evidence there that does work. So I think similarly, when we think about COVID vaccine, it's a rapidly developed, newly evolving situation. So really getting information through trusted channels into the community is going to be really critical to making sure we have enough people vaccinated for it to actually be effective.
Thank you. And Dr. Staats, thank you for sharing the experience at Imperial County. Love to kind of hear your perspective as we approach the winter surge and how your experience currently is going to affect how you think about your response for this upcoming potential third wave and winter surge.
Yeah, thank you so much. It was very helpful, I think, in a lot of ways to have so many stakeholders with the first surge in Imperial County from the state, regional, and local level. Now that we have that sort of framework of what worked the first time, we've now pre-set up many of the resources that it took some time to set up previously. So now, instead of having this alternate care site take time to put people up, we already have that standing by. We are also doing more things to increase our local capacity. So we'll be putting up more tents, potentially a field hospital, and also a really innovative and cool thing we'll be doing is prepping pre-hospital providers to provide home health out in the community rather than put them potentially in an alternate care site. So a few other things to try to increase our local capacity, which we're hoping will offset transfers out.
Great, thank you. And Dr. Hussein, there was a question in the chat box that I believe was directed to you in your presentation. Specifically, when you shared some of your numbers, there was a question about could the access to care or lack of access to care justify or contribute to the numbers that you were sharing with the population affected?
I don't think so. If the question, if the low numbers of the first wave, I don't think it's the case. The case that the epidemiology of COVID-19 in Israel in the first wave was mainly citizens that were aboard and came back to Israel with COVID-19, and almost all of these patients came were from the Jews population, less from the Arab population, and I don't think that there was no patients. If there was severe patients, we will see them at the hospital, and we didn't see the severe patients at our hospital.
Great,
and
thank
actually
you.
in other hospitals. Yeah.
Thank you. And thank you all again for joining our symposium as speakers. I appreciate the very engaging presentations and discussion.